our breakout session. Thank you for staying. What I did was I hid some slides in my slides, and I thought we could talk about a couple of case studies. And then what I'm really hoping is that this becomes an interactive thing, because garments are a real challenge for all of us. And every patient that walks in our clinic that's not like a perfect cone is gonna be challenging. And I'm sure that I'm not the only one that's thinking up some creative ways to do this, because that's the mother of invention, right? Great. We have to figure it out. So if you guys can, I'd love you to make this a more interactive and discussion thing, but I'll start out with one. Have you ever had anybody come in with one of these? This is quite a garment, isn't it? Okay, so I'm just going to go ahead here.
Wait, I did.
Oh, what? This is actually, Joanne helped me with this patient.
Actually, not this one. I actually helped someone at Beth Israel. And I was going to tell you about something that I think you should consider when you're doing toe caps. And that is, people like to cut out the fifth ray, okay, and they leave a hole. If a person has a tailor bunion, and it's pretty prominent, and then you cut out that hole, and you cut it so that it'll continue to expand and expand and expand, what will happen is it will actually aggravate that tailor bunion. So I tend to leave the fifth ray on, particularly if they have a prominent tailor bunion. Does that make sense? No? Has anyone seen this happen with the sensitivity? Because that's an area of big sensitivity. And what happens sometimes when you're putting on a toe cap is you've got an overlap then of an open toe garment. So you've got a combination of the compression of the CA, which is going around the forefoot, and then the little toe with the bunion, happening at the tailor bunion. So it's so important to keep that toe intact if you're doing a toe cap. Yeah.
And this particular patient actually had liposuction and was in her double layer of garments and had a very, very sensitive met head area. She just could not tolerate the compression of two garments. So I think that, a patient like this probably needs to have an extra centimeter, even though it might not be as optimal to, increase that space a little bit, but it's better than them doing this. So my experience, and again, Joanne's better at this, is that if you're going to put your garment on, maybe add a centimeter, like they say, do zero pressure at the met head, but I might add a centimeter, and then on the second garment, I would add another centimeter to make up for that, so that you get less squeeze at the met head, because this patient, she just couldn't live that way. So anyway, that's something to do. She's subsequently doing much better, but that's always fun. Okay, so next patient that I thought I would move on to is Stephen. Oh, how come it's going sideways, the movie? Why did it switch?
Horizontal.
Like it starts that way. Why does it flip horizontal? Eat the AV people. Oh, well, I'm not going to turn on the video because that's just going to give you all a headache. Okay, well, the point is with this guy is that he walks with really stiff ankles, and we all know what really stiff ankles does. He had hammer toe surgeries 12 years ago. Hammer toes, by the way, are earned. That is not really super genetic. There may be a little bit, but for the most part, it's earned. And people that walk with their toes, when they get hammer toes, they grip with their foot, so they're pulling themselves forward in the world. That, to me, is important, because when we're working with garments and patients with lymphedema, what is the number one thing that they need to get fluid out of their legs? They need a calf pump. So my point with this, one of my points with this guy is that he has hardly any calf. Now you look at his legs that he's walking there, and it doesn't look horrible, but I'll tell you what, this is the guy that lost 1,000 mLs in each leg in 2 days. He subsequently lost another 300 mLs in the left leg and maybe 200 or 300 in the right leg. So we got the majority of the fluid out in the first couple of days, but what we've had to work on is the fibrosis. So his fibrosis is out of control. I have never seen such stiff toes. So obviously he's had stiff toes for a long time. You know, he doesn't even seem to really understand when his feet got so bad, but he had those rocker bottom feet. But his pain was like out of control. So he would walk like he was walking on shards of glass everywhere he was going. And he went to someplace else for lymphedema therapy, and they gave him circular knits and a pump and sent him home. And that's all they gave him. And that's really, it didn't work for him, obviously. And again, it didn't work partially because he needed more treatment, but a really big part of it is that nobody addressed his fibrosis. And I feel like I'm melting an iceberg on this guy, because I get my laser out and I pick a side of his foot or a top of his foot or the bottom of his foot, and for whatever time I have with him in the clinic, I just dig away and work on that foot, and then I get my reflex hammer out, or I get my suction tools out, or I get my my Graston tools out or whatever, and I'm working on that fibrosis because he has to get toe motion. He has to get toe motion so that he can actually bend his toes and lift his calf and use his calf. The interesting thing is that as we've gone along, and I don't have any future or pictures that I've had of him lately, his left calf now is smaller than his right calf. He has no muscle. He has no muscle in his calf hardly at all. So trying to get him to use his calf to improve his pump is really tough. So, you know, I would hope that most of us have time to really spend some time on gait, and we happen to have a subspecialty in feet at our clinic, so we do a lot of foot stuff, crazy foot stuff. And so we are always looking at people's gait and always trying to get a better calf activation. He also needs a total shoulder replacement. They won't do it until his swelling is better, because he's just, I think, ripe for an infection in general. He will tell you now that this is a few months later, he will tell you now that his foot pain is 40% of the time he has no foot pain, whereas before he had 10 out of 10 pain all the time. So that inflammatory aspect that I've talked about having to do with the fibrosis is just terrible, and it contributes to their pain problems tremendously, and it makes our lives hard. So now, luckily, I only see this guy once a week. Now, how do I get away with that? Because he has a wife that is going to get a halo sometime in the future. Because they had a pump when I met them. I gave them, or they bought the jelly rolls, so they use the jelly rolls. So he comes in like all primed for me. And so when he comes in, and he wears his garments, he wears bandages still. And I've been treating him now for probably 6 weeks. He is still in bandages. And we've tried a couple of times to drop down to a Velcro or something, and he just blows up at the knee. So he's not ready for that yet, and I don't think I want to put him in garments until the fibrosis gets better, until his foot actually gets better. So he's a lot better now, but I'm still working on it. But I only see him once a week because that's what they can manage. They have other responsibilities at home, but I can do that because he's got a wife that's willing to do the part that needs to be done. So he is still getting 100% of a CDT management program, but he's just doing it at home.
Go ahead and move that ankle now.
So this is the volume.
Now
If I push it again. Okay, so I want you to look at how much toe motion he had when he came in. Barely any, and he had barely any ankle motion. And that was in 7 treatments. 3 weeks later, look at how much ankle motion he had. And you can just see how small his leg has gotten now. But that's with the management of the fibrosis. But it's still not great, but it is improving. So when I have to get to the point of managing compression with him, so I've been talking to him about it right now. So he's going to have something that goes up above his knee. He is not going to be very tolerant of anything slipping down because he has a hard enough time walking and transferring. Oh, by the way, he also sleeps sitting up because he has chronic back pain and 2 failed back surgeries. So that's just the other comorbidities that go with him. So that's another reason I'm having a hard time with his legs, and probably one of the reasons he fibrosed so badly is because he's been sleeping in a chair for, I don't know, years. He's been sleeping in a chair, a sit-up, a recliner kind of chair. So for him, my thought is I'm going to probably get him some sort of a capri some kind of maybe a capri type thing that will cover his knee, and then separate that with a knee high. And so then when he bends his knees and he sits and he stands, which is really challenging for him, the crotch won't be coming down. Because I think that's one of the things that I see with patients in general, especially men. They just don't tolerate the crotch falling down in their garments. And so that makes it really undesirable. Now, maybe he can get away too with another over-the-counter kind of thing too. So maybe some portion of the time he can wear a non-flat knit, but maybe a textured garment like I talked about, some sort of a textured capri, and then maybe wear the Alvarex or the flat knit going up to his knee. But then we're going to have to see how he does, and so he might be able to go back and forth between those two if he manages it. But again, because he has a pump at home, along with the jelly roll thing, he can manage his fibrosis much, much better. So I'm really very interested in helping patients get what they need to make their lives easier. You know, I know that in our Medicare guidelines, it's all about failure, failure, failure. And I like to think, well, despite the patient's best effort of doing whatever they're doing, they're not able to manage it or maintain the changes. And so I'm probably a little more liberal maybe about, you know, a pump. And I want them to try it, because the last thing I want is for a pump to sit in someone's closet. I do not want a pump to ever sit in someone's closet. So I'm very grateful that I have all these pumps at my clinic, because I can have people try them and they can decide, is this going to sit in your closet? How much of a difference does this really make for you? But being able to have that in my clinic and use it as part of my initial treatment, I think helps with the home management aspect. So that, because I think that if the patient doesn't have an opportunity, if they like you say they need a pump and they've never tried it, they don't know what it feels like, they don't really know what to expect out of it, I think that makes it a lot harder. But if you get to use it at the beginning, then they can decide if that's going to be folded into their program. I have several, actually. I have a Lymphopress pump, I have Eros pump, I have VES pumps that I don't think they're sold anymore, but Linda Miller's pump, that was Linda Miller's pump from a long time ago. I have a FlexiTouch pump. So I actually have quite an assortment, and then I have some duplicates of all of those things. So I have about 6 pumps at my clinic.
And how did you get those pumps?
I think it was on.
How did I get them?
Yes.
Well,
the vendors just
They don't just provide them for you. So some of them I had to buy. Some of them I did get as trial units. But you know, maybe you can go to the vendors and talk to them about potentially getting one. Or the other thing is, if your hospital can just get you one in the clinic to try, because I think it really decreases the amount of time that the patients have to keep coming in. So, yeah.
If you talk with the vendors and they realize that you're going to be, one, using it, introducing it to the patients, and perhaps prescribing it, they may be willing to give you a pump. They did give me a pump in my clinic, so you could talk to the vendors.
Yeah.
I have I have multiple. I have the Eros pump, which I find that company personally to be really quick with getting things approved and easy. I just send them the face sheet and I don't have to think about it.
Yeah, and Lymphopress will do that too. So Lymphopress, FlexiTouch, and Eros all have in-house billing, or they'll do the insurance stuff for you, because, I mean, in Vermont right now, there's no vendor for us. So most of them have picked that up.
Yeah, and I find that the Lymphopress personally, I think it works a little better in the foot than the Eros. So when I have a stubborn foot, I'll use a Lymphopress or FlexiTouch as well. So it depends on what the issue is.
Yes.
How are you billing, or are you billing from
that time?
So that's a really good question. So there's all kinds of creative ways ones can do that. And I know that for me, if you're taught, I can have my hands doing one thing and I can be educating a patient with my mouth, right? So it kind of depends on what you're doing with the patient. I've had patients where I might be, I might have a pump on one side and I might be doing MLD on the other side, or fibrosis treatment on the other side, or I might be educating them, in garments or, bandaging or whatever it is that I have to educate them with. So you could do two things at once. I tend to, in my clinic, because I own my own practice, I have them come in early, and I don't actually get paid for that, although I've thought about, maybe I should be getting paid for that. But I fold it into the treatment because I can, and they're using one of my rooms. And they're there for about a half an hour before, but it makes my life as a therapist so much easier to have them decongested somewhat before I go in and start, it takes 45 minutes just to bandage a leg, and by the time you get through the education part, some exercise part, and the rest, the infection control stuff, or it just takes a lot of time. So I tend to have them come in early. But if they can't come in early, then what I'll do is switch legs. I might do something to one leg and then put the pump on the other one and then switch that over. There is a code, but Medicare pays a little bit for pumps, but I don't think it's very much. And some of the insurances pay a little bit too. So you could always put that on your billing sheet, and hospitals obviously get a better reimbursement rate than some of us out in private practice. So maybe you'd have to sort of check with your billing people and see how that works. But I think the value that comes from getting that patient to a better endpoint so that their garments really work for them, and just the change in the bandaging stays on so much better for them. It's so much more effective to get a big swoop of fluid out of that area. Any other questions? Does anybody else have any ideas of what you would do with someone who, by the way, this guy can't reach his feet? Needless to say, if his wife's doing a lot of his stuff. So he's got real mobility problems. He's a problem going from sit to stand. His feet slide out from underneath him because he can't get his hips over him because of his back problem. So, again, breaking those garments up into two different pieces for him will, I think, be really helpful. Does anybody else have any ideas for my patient? You guys could give me ideas for my patient. Yeah. I should go back.
When it comes time for garments, sometimes what I've done is use the the easy slide.
Oh, yeah.
I'll make a napped pad piece that sometimes includes the toes, sometimes it doesn't, or I'll use this Comprex 2 foam and cut the toes and include them. I'll bandage them. Or if I don't want to include the toes, I make a dorsal foot pad that I sneak under the easy slide, put the garment on, they slip it out, and then that foam piece stays in under the garment. You can even do that around the malleoli if that's a stubborn area. And then that just sits under the garment and breaks up that fibrosis all day.
That's really nice. That's a great idea. I've done that too with the foam dots, the orange foam dots. I've done that with that. And then sometimes I use those little orange horseshoe-shaped things too. Yeah. So I think getting something under a garment when you've got someone with just really bad fibrosis can be really helpful. Just have to watch their skin, of course. Yeah.
I think you had another slide as well, but like a Cresia, like a knee high would be pretty helpful on this point. Linda Rorty uses them for some of her patients. Instead of stockinette and padding, she just bandages over the top. And then those patients can use that inside of a pump as well.
Yep.
And they're machine wash, machine dry also. So
the one thing I found with some of the heavier, whether it's a Cresia or the Jovi packs, for some of the patients, at least in the initial decongestion part with the pump, is that it absorbs. If you're only turning it up to 50, it tends to absorb some of the pressures. So if you're going to use one of those heavier chipped foam garments underneath the pump, you might have to turn it up to 70 or 80, even though that amount of pressure is not actually going to be on the patient, because the garment, the foam in the garment is actually absorbing some of that pressure. But you can play with it, and again, it's always to patient tolerance, right? And you can also tell by what happens when it comes out of it. You can give it a try and see how much indentation you get. The one thing that I like about the channel foam, again, is that it doesn't matter what size the patient is, and I can use it right away. And then I may choose at the end, like you said, when they get to the independent stage, to use some other type of a garment, whichever one's going to be best suited for them. Yeah. Comprex is pretty, and it just, I tell you, I went to them at, in Miami I was speaking at the AVLS conference. I've been speaking at a lot of conferences lately. And I went up to Lohmann Rauscher and I said, what is the secret sauce in that foam? I said, I want to know, is it a medium density, a low density? Because it doesn't seem to compress as much as some of the other foams. And I mean, there's all sorts of different densities of foam. So I think it's a little bit of trial and trial. There's no errors here because we're going to try this and try that. So it just depends on what that patient can tolerate. Yeah.
One more thing I do with the pumps too, I have a similar sort of Comprex 2 piece, but I hold it in with a Rosidol soft and I pull that stretch pretty firm so that it kind of cinches it down and conforms already. And that takes away some of the, as you were describing with the Caresia, I've tried that with the bump too, and you're right, it doesn't quite, like the foam almost, it doesn't push down enough.
Yeah.
It's too fluffy or something. So with the Comprex 2 foam, it works pretty well.
Yeah, because you get the actual, because those pumps, all of those pumps conform to the patient's leg. Now, if you didn't have that, you could also, something else I've done is I've done something like take a towel and wrap it around someone's ankle. If I, before I was using these things, just to get extra pressure at an ankle so that, because again, you're trying to create it's easier when you have a straight cylinder or cone shaped when you're trying to apply pressure. So you can take in, or if you have somebody with large lobes, like I have a lymphopod at my practice also, so I treat a lot of my lipedema patients. So if I have a big discrepancy, and maybe I'm not using the channel foam with the lipedema patients, although a lot of my lipedema patients actually really like it. They walk out saying that they feel lighter. So that's really a super plus. But I'll use, again, things to pad up to get more of that cone shaped, even inside of the pump, to get more consistent. And if you had somebody with a lobule, once again, you could pad that up with, again, something that's a little denser fabric, like a towel or something, so that you're actually going to get some pressure in an upward position from some of that. So those are some of my ideas. All right, we're going to go forward. Okay, so this is Michael. So Michael came in to me, and I only saw him a total of 7 treatments. He was undergoing chemotherapy for, I think it was a prostate cancer, and he had some sort of advanced prostate cancer and was being treated out of state. So they were in and out of the state a lot. And he was in his 80s and came in and had a lot of redness and hemosiderin staining in his leg, which is the right-hand picture first. And so I didn't get to see him very long. So he was another one that I did this process with, and I don't have a picture of him at the end, but in the end, what worked best for him, he had problems with mobility. And so I put him in a Velcro garment, and the Velcro garment worked great for him. It kept it down. Once we got the pitting edema and fibrosis out of his tissues, he didn't need a huge amount of pressure. So he fluctuated a lot because I think his chemotherapy was having an effect on the swelling. And so it was hard to put him in any kind of garment. And he was also super sensitive. His skin was kind of tender and thin, and he was very sensitive to pressure. So he just never really tolerated. Before he came in, he was wearing a circular knit, so he just couldn't tolerate much of that pressure. So by using the Velcro with him, it just made a big difference. But one of the points that I have with this slide is I only saw him 7 times. 7 times, and he was managed. A year later, I was in Costco, because Costco is like down the street from my office. My husband calls it the country club, because I just go walk around there after work when I need to kind of just let my brain rest a little bit. He'll say, "Oh, I see you're at the country club," because he follows me on my phone. So anyways, one day I was in Costco and I ran into Michael and his wife, and he proudly pulled up his pant leg and showed me that even in a year later, he was still wearing his Velcro garments and had gotten a new pair, thank goodness, and was totally controlled with that and was totally happy with that. So, once again, really looking at that patient and what's going to manage them and what fills their needs and what will they do. And it gave him a sense of independence because he could get the Velcro garments on by himself, but didn't have the strength in his hands to pull up a traditional garment. So that was Anybody have any other ideas for some of the chemotherapies? Oh, humps and fibrosis at base of toes. How many of you get how many of you get those big creases at the base of the toes? Do you know what works awesome for that is the laser. So with the patient, the laser works really well at the hump of the toes, and then patting that up too when you bandage them with a little bit of foam. That can be very helpful for patients. And then Joanne's got an idea.
Yeah, so typically that hump is difficult to get rid of. And sometimes people think, well, if I use higher compression, that might, the same thing with like a puffy hand. And the higher compression really won't do it. You really need something firm and hard. So an adhesive Velcro wrap for the foot actually will give a nice hard resistance, and then you can put in the compress underneath that to even soften the fibrosis. And then that combined with, again, then wearing an appropriate shoe, you'll do a very good job of being able to get rid of that hump of the foot. And then sometimes at the base of the toes, it gets really hard and crusty, and so you can use those crescent pit packs. You've seen those, they're really tiny, they're crescent. You can get them either with chip foam in it, or you can get them with the cherry pit packs that Lesli, what your nightwear is. You can actually decrease that as well. And a lot of people, that's problematic if they're wearing open toe, if they're using an open toe garment, because where that garment ends, you kind of get that, excess material. So that's the indication then for a toe cap, I hate to say. And you can always use a low profile toe cap. You don't always have to go custom, because sometimes a low profile is sort of like what we use. I just know what we have in ours, but our Pharaoh ones that kind of have the isotoner type of fabric, that's sometimes just enough. You don't necessarily have to go custom, because when you go custom in a toe cap, you're talking like over $300 and some, if not more. And so you can maybe try something a little more low profile.
The first lady that I showed you with the shredded garments, that's what she ended up doing. We got her the thin toe cap, and that actually worked really, really well for her. So she now, because she ended up having the lymph node transfer done down in Florida. So she had the debulking done, and then she had lymph node transfer in Florida, because she lives down there for part of the year. And now she's wearing two, because she's difficult, she's wearing two, she wears a class 3 and a class 2, but they're over the counters. So she seems to be getting away. She has kind of her own ideas on how things should be. So you kind of just go, okay. But anyways, so she would come in all the time with this humped foot, like you see how bad it was humped at the very beginning there, but she would come in with these humped toes. And so she could keep it under control when she would wear her shoe, because her shoe was nice and snug. But then she would take it off and it would hump back up. And so the toe cap worked great for her. So now she's thrilled, because she seems to think that she's just much happier in the over-the-counter products. But it's managing her. Again, she's also a year out of her lymph node transfer. And so what were you guys saying, Cheryl? Like it's a year, 9 months to a year before it really takes effect? Yeah. So for her, it was about a year afterwards, all of a sudden she felt like my leg is so much easier to manage. So instead of being with her team and making these decisions as she probably should have been, she sort of floats in and out of my clinic like every once in a while when she's in town. And anyway, she's a ticket, but she's well managed now. Yeah.
She's wearing off-the-shelf circular knits?
She is. She's wearing off-the-shelf circular knits. Mm-hmm. She's her own boss. She is, but correct. But it's working for her now. It wouldn't have worked for her after her surgery. It wasn't, as you can see. So she was actually wearing the flat knits, which she would cut up, but she wore those flat knits for a good year afterwards, and then she moved herself to the circular knits. Yes. And did you have a question? Someone else raised their hand. Did I get everybody's?
There are just a few questions on the
great.
virtual here. One's asking if you ever use cupping in your treatments.
Yes, all the time. I use cupping all the time, and I have different kinds. I have a Physio Touch or a Lymphatouch cupping unit that I use that's got the vibration with it. I also have another, these are all in other presentations that I have, but I also have another cupping unit that you pump That thing's great. It's really inexpensive on Amazon, and it comes with like little cups and big cups. And I'm never trying to turn anything purple. So understand with cupping, this is not traditional cupping. And it's not for very long. I'm never trying to create a hickey-looking thing, and I'm never trying to create permanent, or not permanent, but long-term redness in the skin. But I am trying to stretch that scar tissue and that fibrosis, and I can be very focused. And on the toes, I use the cupping with the little, there's a really narrow cup with the little pumper thing. And I think it's like, I don't know, maybe $30 on Amazon or something like that. So yes, I love cupping. Yes. Yes. Yeah, so I'll glide the cupping sometimes, and when I can, I'll put a little bit of, we use cocoa butter in our clinic, and a little cocoa butter will make that glide. Yeah, yeah, and then I have a whole bunch of different types of, tools that I have, whether they're Grastons or, ASTME kind of type of tools, or the gua sha tools kind of work. And when I teach a patient to do this at home, I show them how to use the back of a spoon.
There's another question. I think this might be for maybe the whole room. Someone's asking what vendors are people in Rhode Island and Massachusetts using for LymphaPress and Arrows, and they're using a Remarks. I guess they're having a hard time with coverage, so I didn't know if anyone had any comments about the coverage with those pumps for patients.
I think I would go to the pump company themselves, because if they'll do that for us up in Vermont, I'm sure that they will do it for people in Massachusetts. And we're just having, I think that the medical suppliers are just pretty overwhelmed. I mean, our medical supplier in Vermont just decided about a year ago that they weren't going to do any compression garments, and we had nothing. And I had to call and cry and say, you can't leave me in a desert up here. I can't be in a state where I can't get any coverage. Nobody would bill insurance for garments. So I think that in a lot of ways, some of the insurers have just made it really hard for the vendors to actually do their job. And the administrative time is just excessive. And so I'm grateful that some of and I think it's by necessity, these companies have come up with systems within their company where they can actually, they're willing to kind of go forth and, work with states. So I would call the companies themselves and see if they can help you, because that's what I'm doing. I have nobody that will cover a pump up in Vermont. Any other questions? Any other comments, thoughts about toes? Anybody else have toe issues? I had a patient come in just recently, and I tried to get her to get a toe cap, and she did not want to pay for it. She has Medicare, and she doesn't want to. And so I told her what I thought the best thing was going to be. She did not like that, and so we got out toe bandaging. And I had seen her, I don't know, sometime in the past, maybe a year or two ago, and she kind of forgot about toe bandaging because we did that at the beginning of treatment. And so I got out my toe bandages, and I retaught her how to toe bandage. And she walked away fine, and I said, okay, you can try this for a little while. My friend Nicole Stout says to me all the time, cost is good and convenience is better. So we'll see how she does with the toe bandages, but once again, she gets to choose.
What kind of toe bandages do you use?
So I'm using, well, on that particular patient, what brand do you mean?
Yeah, because I just use
Elastomil?
Elastomil. Well, that has Monolast, narrow one. Doesn't,
So I've been using the one that's 2 inches wide so I can fold it in half. That's what I find works really well for the gauze. Yeah, the gauze. But I use it.
time that you can buy something that you can actually wash or reuse. You haven't found that anymore. Bandages Plus.
Yeah. I have patients buy a bag. I mean, if I don't have I don't have that many patients who want, you give them a few of them and they only want to do this for so long, and then they might decide that a toe cap's a pretty good idea. So, but I've had a couple of patients who I just had told them, just buy your own bag. I mean, you can go, unfortunately on Amazon, you can get anything. So buy yourself a bag and use the 2-inch ones because they don't shred as quickly and they get a double layer. And it's also a little softer because it's been folded in half. It doesn't have the the edge that can be really irritating to the toes sometimes. So I use the 2-inch ones and fold them in half. And then I do the loop. You can do each toe, and then you can go back and do the kind of loop up through the bait to give them pressure at the space right here, the web space. So if that's appropriate, if they've got a hard, firm shelf that's starting to grow there, I'll teach them how to get that pressure up there, and then I teach them how to use the back of a spoon, or they have to get their own reflex hammer. The other thing I use for those toes that are really hard is those little vibration tools. This is another lecture, I know, but there's those little teeny mini vibrators that have a rubber tip. Have you guys seen those? Those are great. They're about $30 maybe. And I'll have them sit and vibrate, with some pressure, and actually use that little vibrating tool as well. So again, we try all these things in the clinic, and then the patient gets to choose which thing she wants to use, or he wants to use at home. Any other questions? Yes.
This is just my personal experience. And I do want to thank everyone in this room that's a lymphedema therapist, because you guys make our world so much more livable and functional. So I have, on my right foot, I have a really prominent, what is this, the 5th metatarsal or something. And I went down to Long Island for my care at one point to Bonnie Lisinski. And I was in a toe cap and then the open toe, and it was always creating this really bad pressure point. And I was doing moleskin and, a kitchen sponge or, whatever I was using to protect it. And finally, after many iterations, Bonnie said, okay, we've got to fix this. And then plus I have hammer toes. I do not walk on my toes.
No, it's gripping. It's not walking on your toes. It's gripping. It's not. It's all about how you move yourself forward. You use your calf to push yourself forward. You pull yourself forward in the world.
Okay, I did not know I was a gripper. But anyway, so she modified mine. So I only have 1, 2, 3. I have 3 toes, and then there's a cutout. And it goes at an angle down beyond my bone here. And then my open toe stops before that metatarsal. And it was, that's what I've had now for 12 years. And it was like an aha moment and a hugging and a group hug in the office and everything.
So we've got to listen to our patients. When they say they have pain at those met heads, they have pain, and you can't walk through that. So thank you very much.
So I have actually had 2 patients now tell me about the base of their 5th metatarsal. And sometimes with certain orthopedic problems, as they start losing their lateral arch, and their foot starts to flatten out, what happens is that the base of the 5th starts to become extremely prominent. And I've had 2 people say, oh, the compression's starting to hurt my 5th, their 5th toe. And so when looking at it from an orthopedic standpoint, what they really need to do is they need to get a better orthotic, because the orthotic will actually help. Because if you decrease the compression, you can only decrease it for the whole foot. You can't just decrease it there. And so it becomes problematic. Has anyone ever seen that before with their patients?
All the time. We have to add met head pads in. Sometimes I do a long arch tape.
It's very interesting because it's now an orthopedic problem.
That's an orthopedic problem. So I call it the flipped umbrella. So our forefoot is supposed to have that arch, that comes into the arch of our foot. So our forefoot is shaped like this. And when the patient's like the guy with the rocker foot bottom, he's got what I call the flipped umbrella. So instead of having his forefoot arch be like this, he's flipped like this. So then what happens is they start walking on the wrong part of their toe. And then that's where they start hammering, because they have to, because you can't put your pressure on that, so you start gripping your toe to lift your met heads up off the ground so that you can move forward in the world and not have pain in your feet. So that's where flipping back and forth between the orthopedic realm of, is this a lymphedema problem or is this an orthopedic problem, can be really beneficial to those patients. So when I put the long arch tape on my guy with the rocker foot, he got right up and stood on his foot, and he's like, wow, that doesn't hurt. Because he'll come in and he'll say, sometimes my foot feels fine, I have no pain, and other times it's just killing me. And you go, So that's when I went into, but I had so much swelling on the bottom, I could tell that when I first met him, because I could touch the met heads of his foot and he would just jump off the table. So he had tremendous pain in his met heads, but I couldn't unflip the umbrella, as I say, because he had too much swelling. So we had to deal with the swelling first, and now because you couldn't even like move the skin on the bottom of his foot or the top of his foot. Now it slides around like it should. So now I'm long arch taping the bottom of his foot to tuck his met heads back under, and if that works for him, then if he can tolerate it, again, depending on his pain, we might move to some sort of a met head pad. And sometimes, actually, you know what we use for met head pads? You know those orange dot squares that we get, or the dots? There's one that has like a big, like a 1-inch dot. We use those a lot for our patients that need less lift than a traditional met head pad would provide. And we will cut out one of those dots, put it where it should be, and it gives them just enough proprioceptive feedback to be able to move over that without flipping their umbrella. So just another way you can use different products. So anybody else have any comments on this? So this is Alex. And Alex came in to me, and I wish I had taken a picture of his garments by the end, because I'll have to explain them to you. But that's what his legs looked like at the beginning, so you can kind of see him walking down the hall. Now, his complaint was that he had a total hip replacement, and his pain problem was on the front of his left shin. His therapist, his home therapist, had taken him outside for a walk, and they walked further than he'd walked in a long time. And from that point on, he had shooting 10 out of 10 pain coming up the front of his leg. He did not come to me for swelling. Now, by the way, I've seen him in the past for swelling several years ago. So I looked at him really hard, and he'd had about tens of thousands of dollars of workups, and they looked for, blood clots and all kinds of MRIs and on, and nobody could find any reason for this pain. But he had tremendous pain on his anterior tib and going up the front of his leg. So my diagnosis, and I want you to look at the second picture there. I want you to see that toe up there waving at you. So he walked around with his toe like up in the air like this. I mean, I don't know why, but that's just his habit. And so he used that toe, it would wag as he would walk in the air. So he's using that as a proprioceptive input and also as part of his balance mechanism. So he was using his anterior tib as part of his balance mechanism. So I started treating his toe, and I started treating his anterior tib, and then the other thing is I had to treat his swelling, because do you think that anterior tib tendon was happy with the amount of swelling that was around his muscle and his tendon? It was terrible. So I did my treatment that I showed you, and look what we ended up with at the end. I have never seen, and I wish it looked like he had a bunch of grapes. The venous disease that this guy had was just the worst I've ever seen in anybody. So I tried to get him into, and he wouldn't bandage at all, and he would not wear traditional garments. He just would not do it. Would not at all. He's an humongous advertising executive from New York City. So he had a very strong opinion as well. And you remember Alex? So anyways, what we ended up doing with Alex was I got him down using my pump system, because he wouldn't bandage at all to get that down. And then we used a Velcro wrap, and then when his knee started swelling, no surprise, we finally put him, well, he had it at home already, some sort of a, I don't know, neoprene or elastic knee brace of some sort. So in the end, he ends up with a Velcro wrap and a knee brace that I don't even know what brand it was. It was something he already had, but it kept his swelling down, and he was happy, and he's still wearing it today, and he has no anterior tib pain because we took all the fluid most of the fluid out from around his muscle, did a little orthopedic stuff, worked on his balance a little bit minimally because he doesn't want to come in. But so that's what we ended up doing for Alex. But again, he had that anterior tib pain for probably 4 or 5 months before he came to me. So he'd seen a lot of people and spent a lot of money. So anyways, that fluid creates a lot of problem in the orthopedic world.
Do you ever flux in the lateral aspect of his foot.
Yeah,
So he has an inverted heel.
correct.
Did you ever mobilize that heel?
I tried.
Did you? Okay, I knew you did, but.
I tried, but I only saw him a total of nine.
Crazy, right?
I only saw him a total of 9 treatments, but, you know, he kind of got good enough, and then he was good enough. So, yes, normally you can see that he's not putting his foot on, that toe's wagging, so he was walking on the outside of his foot. So there's another one that I saw a total of 9 treatments.
I have a quick question about him, I'm
Yeah.
sorry. If he was agreeable to bandaging or compression, given the extent of his venous disease, what would you lean towards?
What would I lean towards with him? I would have, well, because of his age and his dexterity issues, I probably would have put him in a flat knit class 2, you know, because he's venous more than he's, you know, hard primary lymphedema. That probably would have been my personal choice for him. And then in his toolbox, I probably would have given him a Velcro too and said, you can kind of go in between these two. But I think that the class 2 would have been good for him. Now, the problem with the class 2 to the knee would have been he still got the knee swelling. So then I probably, well, again, it's his personality. If he didn't have any personality issues, I probably, I might have gone with a Velcro for the knee and above, maybe a thigh-high kind of thing, because there's no way on this earth that he was going to wear a pantyhose or any kind of thing like that. So that's probably what I would have done, is maybe done a Velcro above a class 2 flat knit. That probably would be better, but again, he's getting along fine, huh? Custom seamed.
Yeah, you could do a custom seam, because vascular anomalies do really well with that.
Oh, yeah. Yep. So anyway, those are my cases. Does anybody have any other ideas or thoughts? Any other like weird cases that you guys want to talk about? Yes.
Did you ever come up with a solution for pantyhoses and people having to go to the bathroom many, many times?
No.
'Cause that's always my issue, is that they don't want to wear pantyhoses because they can't get them off fast enough, especially if they are on any kind of diuretics.
Yeah, I don't know that I have a great, she might.
So those type of people who really do need the coverage going up to the thigh, because otherwise, a lot of times female figures have sort of like an inverted champagne bottle for their thigh shape, is a bilateral chap. And that would be comfortable for them. And then in order to keep the inside from not falling down, you just put a silicone band all the way around at that level. So, you know, and that would work for them. But I know what you mean. But you can always go with lesser panty compression, right? And right, exactly.
Thank you very much for all of that. A little different way. Thank you, Leslie.